Welcome to Optimal Health, your trusted space for deep dives into the health topics that matter most. Today, we're opening a door that is too often kept closed. We're going to talk about sex. More specifically, we're going to talk about the changes, the worries, and the "is this normal?" questions that arise as we navigate our sexual health through our 50s, 60s, 70s, and beyond. These questions can feel isolating, embarrassing, and are frequently whispered to a search engine in the middle of the night. But they are profoundly human and incredibly common. Our goal today is to replace silence with science and embarrassment with empowerment. We're going to tackle 10 of the most pressing questions about sex and aging, armed with medical facts, expert insights, and practical solutions. Before we begin, a crucial reminder. This video is for informational purposes only. While we will be citing established medical knowledge, your body and your health journey are unique. Please consult with your personal healthcare provider for any medical advice or treatment. Now let's begin. Question 1. For women. Why is sex suddenly so painful? It never used to be. This is without a doubt one of the most common and distressing issues faced by women during and after menopause. You are not alone. The clinical term for painful intercourse is dyspareunia, and in postmenopausal women, the leading cause is a condition called genitourinary syndrome of menopause, or GSM. Let's break down the science. The hormone estrogen is the primary caretaker of your vaginal and urinary tissues. It acts like a master architect, ensuring the vaginal walls are thick, supple, and rich with collagen and blood vessels. It also signals the glands to produce natural lubrication. When menopause occurs, estrogen production from the ovaries plummets. Without this hormonal signal, the architecture changes. The vaginal walls become thinner, less elastic, and more fragile, a condition called vaginal atrophy. The natural lubrication process slows down dramatically. Imagine trying to slide down a dry, rough playground slide versus a smooth, wet one. The friction, irritation, and potential for tiny tears and inflammation become significant. This is what causes the burning, stinging, and deep pain many women experience. So what can be done? The good news is, this is highly treatable. First, lubricants. It's crucial to understand the difference between a moisturizer and a lubricant. A lubricant is used during sexual activity to reduce friction. Look for high-quality, water-based, or silicone-based products without parabens, glycerin, or fragrances that can cause irritation. Second, vaginal moisturizers. These are different. They are used regularly, 2 to 3 times a week, not just during sex, to help restore moisture to the tissues themselves. Think of it like using a daily moisturizer for your face. For many women, these are not enough. The gold standard medical treatment, as confirmed by the North American Menopause Society, NAMS, in their 2020 position statement, is low-dose, local estrogen therapy. This is not the systemic hormone therapy that carries more risks. This is estrogen delivered directly to the vaginal tissues via a cream, a small tablet, or a flexible ring. It works locally to rebuild tissue health with minimal absorption into the rest of the body, making it a very safe and effective option for most women, even many breast cancer survivors. Don't suffer in silence. This is a medical condition with excellent medical solutions. Talk to your doctor about GSM. Question 2. For men. I'm having trouble getting or keeping an erection. Is this just what happens when you get old? While it's true that the incidence of erectile dysfunction, or ED, increases with age, it is absolutely not an inevitable, untreatable part of getting older. More importantly, you should think of ED as a check engine light for your overall cardiovascular health. An erection is, at its core, a cardiovascular event. It requires a complex sequence. Your brain sends arousal signals down your nerves, which causes the release of chemicals that relax the smooth muscles in your penis, allowing blood to rush in and fill the erectile chambers. For this to work, you need healthy nerves and, crucially, healthy, unobstructed blood vessels. The leading causes of ED are conditions that damage those blood vessels. This includes atherosclerosis, or the hardening and narrowing of arteries due to plaque buildup; high blood pressure, which damages the delicate lining of the arteries; diabetes, as high blood sugar is toxic to both blood vessels and nerves; high cholesterol. The blood vessels in the penis are significantly smaller than those in your heart or brain. This means they are often the first to show signs of blockage. This is why ED can be a powerful early warning sign of underlying heart disease. In fact, a landmark meta-analysis published in the Journal of the American College of Cardiology found that men with erectile dysfunction have a significantly higher risk of future cardiovascular events like heart attack and stroke. Other causes can include low testosterone, nerve damage from surgery, or conditions like Parkinson's, and psychological factors like stress, anxiety, or depression. Many common medications, especially for blood pressure and depression, can also contribute. The takeaway? Don't just buy a pill online, see your doctor. They will investigate the root cause, which includes screening your heart health. Treatments are highly effective and range from lifestyle modifications, like improving your diet and exercising, to oral medications like sildenafil, Viagra, and tadalafil, Cialis, which work by helping to relax the arteries and improve blood flow. Question 3. For everyone. My sex drive has completely vanished. Is it gone for good? A shifting libido is one of the most universal experiences of aging, affecting both men and women. It's rarely a simple on-off switch, but rather a complex interplay of hormones, physical health, and psychology. Let's start with hormones. For women, menopause brings a sharp decline in both estrogen and testosterone. While estrogen is key for physical comfort, testosterone is a major driver of sexual desire in both sexes. For men, testosterone levels decline much more gradually, a process sometimes called andropause, at a rate of about 1 to 2% per year after age 30. This slow decline can certainly contribute to a less urgent sex drive. Next, physical factors. If sex is painful for a woman, or if a man is anxious about his erectile function, desire will naturally plummet. Chronic pain from arthritis, fatigue from other health conditions, and medication side effects all drain the energy reserves needed for sexual intimacy. Finally, and perhaps most powerfully, psychology. Decades of research, including extensive resources from the National Institute on Aging, NIA, emphasize that psychological and relationship factors are paramount. Stress about finances or work, unresolved conflict with a partner, grief, depression, and poor body image can be absolute libido killers. So, is it gone for good? Almost certainly not, but it may have changed. Renowned sex therapist Esther Perel often discusses the difference between spontaneous desire, the kind that seems to hit you out of the blue, common in your youth, and responsive desire. Responsive desire is the kind that awakens in response to stimulation and intimacy. It needs to be courted. The key is to stop waiting for lightning to strike. Schedule time for intimacy. Focus on sensuality, prolonged kissing, massage, showering together, without the pressure of intercourse. This deliberate focus on pleasure can often be the spark that awakens responsive desire. And of course, addressing the underlying physical and hormonal issues is a critical first step. Question 4. For women. This is mortifying, but I sometimes leak urine during sex. What is happening? This is far more common than you could ever imagine, and it has a medical name: coital incontinence. It's important to know there are two main types because the cause and solution can differ. The first is stress incontinence. This happens when physical pressure, like from penetration, changing positions, or the muscular contractions of orgasm, Pushes on the bladder. If your pelvic floor muscles, which act as a supportive sling for your bladder, are weakened, they can't keep the urethra closed, and a small amount of urine leaks out. The second is urge incontinence. This is caused by an overactive bladder muscle that contracts involuntarily. For some women, the intense nerve signals and muscle contractions associated with orgasm can trigger the bladder to spasm and empty. Why does this happen with age? The pelvic floor muscles can be weakened by childbirth, chronic coughing, being overweight, and crucially, the loss of estrogen during menopause, which helps maintain muscle tone. This is not something you have to live with. The number one first-line treatment recommended by organizations like the American College of Obstetricians and Gynecologists, ACOG, is pelvic floor physical therapy. A specialized physical therapist can use biofeedback to teach you how to correctly identify and strengthen these muscles. It's far more effective than just guessing at Kegels. Practical tips in the meantime include emptying your bladder right before sex and experimenting with positions. Positions where the woman is on top or spooning often put less direct pressure on the bladder. Question 5. For men. It takes me much longer to get aroused, and I need more stimulation. Is that a sign of a problem? This is a completely normal, expected, and physiological change of aging. It is not a sign of a problem or a lack of attraction to your partner. Let's revisit the mechanics of an erection. It's a neurovascular process. As we age, two things happen. First, there can be a slight decrease in nerve sensitivity in the penis. The signals just aren't as strong or as rapid as they once were. Second, the vascular response, the speed at which blood flows into the erectile tissue, is also less robust. The result is a change in the arousal threshold. In your 20s, a passing sexual thought or a fleeting visual might have been enough to trigger a physical response. In your 60s, 70s, and beyond, your body requires more direct, intentional, and prolonged physical stimulation to cross that threshold and achieve an erection. This is a critical piece of information to communicate to a partner. If a partner is unaware of this change, they might misinterpret it as, "He's not attracted to me anymore," or "He's not interested." This can lead to hurt feelings and anxiety, which only makes the situation worse. The reality is, this change in physiology necessitates a change in technique. It's an invitation to expand your definition of foreplay and to spend more time on manual and oral stimulation. See it not as a deficit, but as an opportunity for more creative and connected intimacy. As noted in numerous urological health guides, including those from the Mayo Clinic, this adaptation is a cornerstone of a successful sex life in older age. Question 6. For everyone. My orgasms feel different, less intense, or harder to reach. Why? The quality and intensity of orgasm can certainly change with age, and the reasons are tied to the vascular, neurological, and muscular changes we've been discussing. For women, reaching orgasm can become more challenging. Reduced blood flow to the clitoris and vagina can decrease sensitivity. The thinning of vaginal tissue can also mean that orgasm from penetrative sex alone, which was already difficult for the majority of women, becomes even less likely. Many women find that as they age, direct and dedicated clitoral stimulation is no longer just a preference, but a necessity for orgasm. The muscular contractions during orgasm may also feel less powerful or rhythmic. For men, the changes are often more noticeable. The force of ejaculation is reduced. The muscles responsible for propulsion are not as strong. The volume of semen decreases. We'll cover this in more detail next. The orgasmic contractions may feel less intense. The refractory period gets significantly longer. This is the mandatory recovery time after ejaculation before another erection is possible. This can increase from minutes in a young man to many hours, or even a day or more, in an older man. This is a normal physiological process. The key here is a psychological shift from peak performance to present pleasure. Instead of chasing the exact feeling you had at 25, focus on the sensations you are experiencing now. For women, this might mean incorporating a vibrator, which can provide the consistent, strong stimulation that may now be required. For men, it means accepting that the experience is different, but no less valid or intimate. A study in the New England Journal of Medicine on sexual function in aging highlighted that subjective satisfaction with sex often remains high, even when physiological responses like orgasmic intensity change, as long as couples adapt their expectations and activities. Question 7. For men. Is it normal for the amount I ejaculate to be so much less? Yes, this is an almost universal and benign change for aging men. The volume of your ejaculate is determined by the fluid produced by several glands, primarily the seminal vesicles and the prostate gland. As men age, a few things happen. The function of these glands can become less robust, and they simply produce less fluid. Testosterone levels, which also influence semen production, are lower. Furthermore, age-related changes in the prostate, like benign prostatic hyperplasia, BPH, can sometimes affect the mechanics of ejaculation. A gradual decrease in semen volume over the years is considered a normal part of the aging process and is not by itself a sign of a health problem. When should you be concerned? You should see a doctor if the change is very sudden or if it is accompanied by other symptoms such as pain during ejaculation, blood in your semen, hematospermia, noticeable changes in urination, like a weak stream or difficulty starting pain in your lower back or pelvis. These could be signs of an infection like prostatitis or other prostate issues that need to be evaluated. But for the vast majority of men, a less voluminous ejaculate is simply another line in the story of an aging but healthy body. Question 8. For everyone. My body has changed so much. How do I feel sexually confident with wrinkles, scars, and a belly? This question cuts to the very heart of the matter. We live in a culture that relentlessly worships youth and a very narrow definition of beauty. It can be incredibly difficult to feel desirable when your body reflects a life lived, with its scars, stretch marks, wrinkles, and changes in shape. Overcoming this is an internal job, and it requires a conscious, deliberate shift in perspective. First, shift from aesthetics to sensation. Try to move your focus away from what your body looks like and anchor it in what your body can feel. Appreciate the warmth of your partner's skin, the pleasure of a gentle caress, the capability your body still has for intimacy and connection. Your skin may be looser, but its nerve endings are still there, ready to transmit pleasure. Second, practice gratitude and neutrality. Instead of judging your belly, thank your body for carrying you through life. Instead of hating your wrinkles, see them as evidence of decades of laughter and expression. This isn't about forcing yourself to love every change, but about moving from a place of harsh criticism to one of neutral acceptance. Third, and most importantly, is communication. This is where vulnerability becomes a superpower. So often we project our own insecurities onto our partners, assuming they are judging us as harshly as we judge ourselves. The truth is, your partner is aging right alongside you. They have their own insecurities. Sharing your vulnerability, saying, "I feel self-conscious about my stomach," or "I'm worried you don't find me attractive anymore," can be terrifying, but it is the fastest path to deeper intimacy. Hearing your partner respond with reassurance, "I love your body, it's the body of the person I love," is more powerful than any external validation. This mutual vulnerability builds a fortress of trust where both of you can feel safe and desired, exactly as you are. Question 9. For older adults. I'm single and dating again after decades. Do I really need to worry about STIs? The answer is an absolute, unequivocal yes. This is one of the most critical public health messages for older adults today. The assumption that sexually transmitted infections, STIs, are a young person's problem is dangerously false. In fact, data from the Centers for Disease Control and Prevention, CDC, shows staggering increases in STIs among adults over the age of 55. We're seeing dramatic rises in cases of chlamydia, gonorrhea, and even syphilis in this demographic. Why is this happening? It's a perfect storm of factors: lack of pregnancy, risk. Postmenopausal women are no longer concerned about getting pregnant, so the primary driver for condom use for much of their lives has been removed. Increased sexual activity. The advent of effective ED medications has allowed many older adults, particularly men, to remain sexually active for longer or to resume sexual activity. A knowledge gap. Many older adults who are re-entering the dating world after the end of a long-term monogamous relationship, due to divorce or widowhood, may not have the same safe sex education that younger generations have grown up with. They simply aren't in the habit of thinking about it. Physiological vulnerability. The thinning of vaginal tissues we discussed earlier can make women more susceptible to micro-tears during sex, creating an easier pathway for infections to enter the body. The rules of safe sex do not have an age limit. If you are not in a long-term, mutually monogamous relationship where both you and your partner have recently been tested and know your status, you must use condoms every single time. Get regular STI screenings as part of your annual physical. Your doctor will not be shocked. They will be impressed by your proactive approach to your health. Question 10. For everyone. What is the single most important thing for maintaining a healthy and fulfilling sex life as we age? If we could distill all of this information down to one essential takeaway, it would be this: radical adaptation and courageous communication. Your sex life at 65 will not look the same as it did at 25, and it shouldn't. Trying to perfectly replicate the past is a recipe for frustration. The goal is not to turn back the clock, but to learn to tell time differently. Adapt your definition of sex. Intimacy is a vast landscape. Intercourse is just one feature in it. Broaden your sexual repertoire to include everything that brings you and your partner pleasure and connection. Sensual massage, oral sex, manual stimulation, mutual masturbation, or simply intimate, non-sexual touch. Adapt to your body's new needs. This is practical adaptation. Use lubricants and moisturizers generously. Take more time for foreplay. Find positions that are comfortable for your joints. Use pillows for support. Work with your body, not against it. And underpin all of this with courageous communication. Talk about what feels good. Talk about what's changed. Talk about your fears and your desires. A problem shared with a loving partner is a problem halved. A pleasure shared is a pleasure doubled. It is in these honest, vulnerable conversations that the true intimacy of a long-term relationship is forged. A fulfilling sex life in your later years isn't about defying age. It's about embracing the wisdom, depth, and connection that only age can bring. Thank you for joining us on Optimal Health. We hope this discussion has provided clarity, comfort, and confidence. Sexual health is an integral part of your overall health and well-being at every stage of life. If you found this video helpful, please consider liking and subscribing for more deep dives into the health topics that matter to you, and share your thoughts or questions respectfully in the comments below. Until next time, be well and be kind to yourself.